So unbelievable. It is week 9 already. It's amazing. It goes by quick. Next week, we are going to do your exam. Remember, this week is all your reviews. What I have planned to do Thursday at 2 p.m., I'm going to do a review. I'm going to do that normal PowerPoint. What I've decided to do is to do an open session where I quiz y'all on things that could be. So it's like an extra on those students who really need to get a good grade on this exam. So on Tuesday, to follow the review, I'm going to be doing probably like 3:30. I'm going to be doing one of those ask me questions. What concept don't you understand? How can I make you understand it better? Okay. So that's for those students who really, are trying to make it and are right there and want that little cushion for the HESI. Now, HESI, I know you're all worried about it. What I am going to do on next week on your exam day, I'm going to start HESI reviews. I have 2 different reviews that I do. There are 2 HESI things. I do one in one class, one in the other. So that's going to be almost 200 questions that you can practice. And then what do? On Sunday before the week 11, so week 11 on Sunday, I do an open forum. I'm going to go over every concept you might see there, okay? I will be sending you like 15 different topics, and there's subtopics to it. And it will all make sense if you come to that question and answer. Most students who come to that, I think, Justin, you came to it last time, it works, it helps. And they tell me what I tell them, it's spot on. So if you want to pass the HESI and do well, I'm giving you every opportunity to do it, okay? You're going to have
Professor?
all the tools you need. Yes, Kendria.
Will you be posting that online?
You
or
get
no?
everything. You get everything
Okay.
I do. Don't worry. And the one from last semester is already on there. So don't worry. But every semester I go back, I look at the HESI, and there's this thing called a gap analysis, that thing that we do, to look at the topics and concepts and things that are missed. I go back and make sure all of that is on that new question and answer HESI review. So it's a little bit different, but mostly the same, okay? All right, let's go ahead. Don't worry. So next week, we're going to do one right after class. So if some of you are not taking this exam on, with me, remember class starts at 4:20, and we're going to be doing that HESI review Kahoots that I have. And again, of course, you get all my Kahoots. You get all the recordings, you get all of the everythings. And again, I try to put it in one place for you so you don't get confused, all right?
Did you say that was tomorrow or today?
The Kahoots?
Mm-hmm.
No, the Kahoots were starting next week. And then it will be that Sunday of week 11. And that will be that question and answer one. So there'll be 2 Kahoots that you're going to get from me, recordings from Monday and Wednesday class. Okay. And that Sunday, we're going to do the question and answer, and that will be posted too. So you have a little bit of everything. You've got everything for everybody to get a 99.99. How does that sound?
Do we have an exam? A quiz today?
No quiz today.
Oh, okay.
Isn't that wonderful?
That is actually.
Last week was quiz 5. Yes, it's very exciting. I agree. I had to think again myself. I had some student first thing this morning say, hey, I don't remember. Do we have a quiz? Well, we've already done quiz 5, so I guess you've had enough.
It said
No,
quiz on it. Okay.
I can give you a quiz if you want. Oh, okay. I wouldn't do that to anybody. So we're going to go over neuromuscular.
Only if it makes my grade better, I'll take a quiz.
Well, I just told you how to do your grade better, right? You can Thursday after the review, stay over. We
I'll
can
be
work.
there.
We'll get you. We'll get you there. You give me your time and I will help you. Okay. And I do it, in a manner that's so easy that you can never forget it. And I've had students tell me they take their HESI and they can hear me talking. So that's a good thing actually for y'all.
Yeah.
There is a discussion question due. And there is a dosage calculation worksheet. Now that dosage calculation worksheet is worth 1%, so it's worth some weight to it. Also, I'm going to be posting 7th and 8th edition, what you're going to do. The modules have a worksheet for the 7th edition if you have the hard copy book. I'm going to be posting the 8th edition, which is the online version of Calculate Confidence too. So whichever edition book, use that one. Okay. All right. So discussion question and a dosage calc worksheet. And all your answers are there. You just got to go through and look at them. And hopefully that helps somewhat also. All right, a mobilized child. You know, one of the things that can happen in children is that they're immobile, either from birth or because of, or due to an injury. And that can actually cause a lot of issues with a child. So if we think about it, there are children that are born, let's say, with osteogenesis imperfecta, which is brittle bone disease. So they're never going to be able to walk because their bones are that brittle. Some degenerative disorders, we're going to go to something called Duchenne muscular dystrophy. Or how about even Guillain-Barré? It gets to the point where you can't, right? So you are flat in bed and can't even breathe. And then, of course, any infections or injuries. And, you know, during that, we need to do a lot of therapies to keep these children feeling better. Now, what happens if we're in bed a long time? Does it matter if you're an adult or a child? Well, if you're not moving your muscles, they're going to start getting very weak, atrophied muscles, right? You're not going to have that flexibility. Foot drop, one of the big things you see in adults, right? Those foots go down because now they're starting to wear booties and they're starting to do the physical therapy. Their bones demineralize and they get weakened. Cardiovascular, you're going to get, you know, can you turn, cough, and deep breathe in a mobilized child, especially if they're intubated, paralyzed, sedated? You know, that's usually your immobilized child up when they're ill. So we need to keep those lungs moving. We need to keep those the heart moving. Prevention of dependent edema, venous stasis, you know, blood clots. All of that is, whether you think it's just adults, children can get that sick and they can get those decubitus ulcers and breakdowns also. Now, another thing that can happen, now they're up and, you know, they're alert and they know what's going on around them. Can you imagine how they feel, let's say, stuck in a room alone for extended periods of time because they can't be out of bed due to many different reasons? So diminished environmental stimulus. So they're going to get depressed. They're going to start to get angry. They're going to get aggressive because they're just so isolated. So it's a feeling of frustration, helplessness, and anxiety. I mean, a lot of times in pediatric hospitals, we've got all different sort of stuff to help these children. We have child life with them. Many times I would have a child like that. And instead of taking my little computer and rolling it out by the nurse's station, I'd wheel it into the room with those children, you know, and just spend time with them and maybe turn on a TV program and watch it with them as I'm, you know, doing my work too. Those things actually help those kids a lot and keeps them from getting that aggressive. Now, can you, a kid who is immobile, can't get moved around, cerebral palsy, they need help up and moving around, Duchenne muscular dystrophy, we're going to go into that later on in today's lecture. What about that osteogenesis imperfecta? What about that child who has been in a motor vehicle accident and has a fractured femur, is on traction, and all of these things? What does that do to the family and the siblings, right? So these children will get to a certain point and then they'll be sent home. Families need all the equipment, support, and they need help. Many times I have seen these parent groups. Now, working in a pediatric hospital that I did for the last 20 some odd years, every unit had parent groups. And the cardiac had parent groups. And I mean, you know, and there was, of course, neurology, the PDICU, the NICU. I mean, all of them had it, but very close to the cardiac area of this. And these parents would get together once a month and they would talk. And they would talk about all of what's going on with their child and their feelings. Also, how to get certain things that the insurance wouldn't let them get, or medical needs, equipment, stuff that people can't find that they need. These groups really work together, and they became families, not just parent groups. They became families working with each other. I know I still am very close with some families that children came out of the cardiac ICU, and the children died eventually, and I'm still very close with them. You become that family. Now, children, traumatic injuries, this is what they do, right? They go out, they run, they jump, they play, they bump, they get bruising, they twist their ankles, knees, ligaments, they do all that. And especially if they're in sports too. Contusions, well, a contusion is a bruise, no big deal, right? Well, sometimes that bruise can go inward and it can occlude blood flow. So one of the things with occlusion is to always check distally blood perfusion. The neuromuscular signs we're going to check, we're going to check pulses, capillary refill. Those things are going to be important that we do check. That bruise could have been a crush, or it could have just been something they ran into or fell onto. But remember that contusion is blood underneath, and it could go down and it could stop circulation. Always in anything in orthopedic, always check neurovascular signs and your capillary refills. One of the key things that we do as nurses, and we teach our parents. Now, dislocation, the bone comes out of the socket. Many times in children, the one that we see is what we call nursemaid elbow. You take that little 2 or 3 year old with very nice, soft, stretchable tendons, right? And you take their hands and you take and swing them around. Sometimes their elbows can pop out of joint. And when that happens, it causes a lot of pain. That arm hangs to the side, and they go into the doctor, urgent care, or ER, and they just go click and they put it back in. And then they tell you, don't do that again, and immobilize it. And that's not really a big deal, because it does happen a lot with children. And it doesn't even hurt getting put back in. In fact, there's a sense of relief. Now, one of the things that Down's children is extremely flexible. Some of your assessments, did mention that. These children can put both feet behind their legs, right? Both feet behind their head. What happens to their hip joints? They can pop. Now, the problem is when the hip joints pop, it really can decrease the amount of blood flow going there. So then we worry about not getting that blood flow, and it could cause injuries with that head of the femur. Sprains, I think we've all had a sprain. We're walking down the street chewing gum and we trip over a pebble, right? I mean, that's always been me. I always did it playing sports. Go up to spike a ball, come down and right on the ankle, and I could hear it ripping. It is all about the muscles, the tendons, the nerves, blood, and it swells instantly. I mean, it got to the point with me playing volleyball, I would go up, spike, feel it, go, oh goodness, and stick my foot straight up in the air, elevate it immediately. And it did decrease the amount of swelling. Strains is usually when you're doing a certain type of movement over and over and over and over again. And they're like little microscopic tears, but they do hurt also. So what's the treatment? Well, I told you elevate it, right? That's always number one, but it's rice. Rest it, ice it immediately because it causes vasoconstriction, stops that swelling. Compress it, ace bandage, put it on there immediately right away and elevate it. Today, we're doing more casts on sprains. Years ago, all these sprains I ever had, I never got any sort of splint, cast, or anything. They were up there with an ace and said, just don't put weight on it. Well, today they are actually casting them, especially those bad sprains, to keep them immobilized and to support them, or at least a splint is put on for them. Now, fractures. Kids get fractures, right? What do? They go on the playground, fall down, they put their both hands out, and fractured wrists, radial ulnar, are the most common of all broken bones of children, because you put your hands out when you fall, right? Now, infants, extremely difficult to break their bones. If a bone on an infant is broken, it's most likely a child abuse case. Now, I did see one case, and it's not a nice story, of a 3-month-old infant came in and had some yellow-green sort of swelling in the back of the ear, and the baby was crying, and mom was holding that infant and was just really concerned. So ER was busy, but the way the mother was, and it was an infant, I brought them in early. When I tried to pick up that infant by underneath the head, underneath the butt, to put it on the scale, my thumb went into the scalp. And I said, oh my goodness. And then I looked at the area and I saw like old bruising, that yellow greenish, right? So I went into the charge doctor and the charge nurse, let them know my suspicions. My goal now with any suspicion is protect the child. I can't get angry at the mother who brought them, or I don't know who did this. I have to protect the child. That's my job. So the doctor said, can you take this child over and just do what we call a bodygram x-ray? Now, infants fit on an x-ray film, right? The x-ray can hold a whole human's chest. You put the infant on it. Not only did the child have a fractured skull, had a fractured humerus, fractured ribs, and a fractured femur. Definitely child abuse. Well, this child was a twin. We called the twin in. Same thing. Had a 2-year-old brother, called him in. He was walking around on a fractured femur. Now, what did we do? Well, we called in all the authorities, what we should. We protected that child. We admitted him until we determined who had done this. And what it came out to be was the mother was working so many jobs because the father had lost his job. And the father was taking care of the kids and was giving them a bath. And the kid wouldn't shut up. So they took the child and swang him and hit the tile surround in a tub, cracked the head. That's where that one came from. Now, the children are safe today. The father is where he needs to be, in jail. And I can't imagine the poor mother dealing with all of that with her children. Now, horrible case I've ever seen of child abuse, as in physical abuse, but it's something that I'll never forget. And because I was that first run nurse that saw them, I protected the child because the father did come to the ER. So we did protect that child. Sorry if you don't like that story, but it really emphasizes what can happen and what your position as a nurse is protecting. Okay, types of fracture. Well, the two that we always talk about is open and closed, right? Simple or closed, it just cracks and there's no protrusion of the skin. Open is also called compound because it's not just a fracture, it's compounded with it being open. And that's how I remember the name open and compound. Well, if a bone is gone through the skin, it's now going to get infected. So we have to make sure that we start those IV antibiotics priority soon as possible, because it can become a systemic problem. You could lose that arm, that leg, or whatever it is. And then there's the complicated or commuted, and they're just bone fragments and take a lot more to align them. And many times those need surgery in order to get them into line again. Now, children are growing, right? Where do they grow? Well, they grow from the epiphyseal plate. It is the weakest point of the long bones. So it could be in the femurs, the elbows, the humerus is a long bone. And a lot of times they'll fall off the monkey bars and come down on their elbow and it will break. And you can see there's a little bit to a lot. Well, if we don't fix that growth plate and make it straight and aligned, what's going to happen? Well, the bone won't grow as well as it should. So you might have a shorter arm or a shorter leg, or it could be crooked. So we do an open reduction internal fixation surgery. We put pins and screws and get that growth plate where it should be. So growth plate, epiphyseal plate, that's where we're most concerned about fractures. Now, have you ever wondered why children only take and have a cast on for 4 weeks. In adults, it could be
Excuse
3,
me.
4, 6 months. Yes.
I was under the impression that if their growth plate was affected, it does not, it actually doesn't heal back again.
They do that screws and the plates on it because maybe that place doesn't grow, but the whole bone is still going to grow. You're not going to have a short leg or a short arm, Lisa. It will grow, but it could be crooked or it could be shorter. So you've got to get that into place with that surgery with pins and screws. It holds it and maintains it in position.
Oh, wow, that's great. Okay, thank you.
No, you're welcome. Now, as I said, have you ever wondered why we're in casts for 3, 4 months and children, they're in it for a month? Well, it's their bone healing. They heal rapidly. Look at the infants, 2 to 3 weeks. We use that a lot with club feet, which we're going to come into next. Putting serial casting on them. Those children, the young kids, it's usually on the last day of school, right? Today's the last day of school down in Miami. I wonder how many kids end up in the ER with a fractured arm or leg. Well, the first 4 weeks, they're not going to be able to swim, right? Because you can't get casts wet. And then as you get older, it takes longer and longer. And that's the concept to remember about molding and healing of bones. So how do we diagnose the fracture? Well, number one, you're going to see the swelling and the pain, and the kid's going to hold it, and that history is going to tell it to you. But you're going to do an X-ray. Now, that little picture, the upper picture, is a fracture that you may see swelling or not, because it's pretty well much in alignment. So that one, you need an X-ray to really look at it. Also, if it's in the leg, if you see them, they're not walking on it, it's painful, you can almost say that that's going to be a fractured something with the leg. And our goal, well, we want to reduce it, we want to immobilize it, we want to make sure that that arm, the leg, the finger, the toe, whatever, is going to function normally when we're done. And we're going to prevent those deformities. I mean, I put a picture of a child down there that's the obvious child abuse, but mine was very subtle, where I had to go looking. My finger went in the wrong place. It was not fun. So, assessment of fractures. What are you going to look for, and what are you going to teach your parents? Well, if the pain is increasing, not getting better, something's wrong. Paler, just getting pale. Is there blood flow? Not much. Pulselessness or paresthesia. We're not having a pulse, no blood flows going down there. Neuromuscular signs, capillary refill is going to be greater than, could be a lot, right? And then the numbness, the paresthesia, and then sometimes you feel the compartmental syndrome. It's big pressure. I mean, that arm to the right is the extreme, but that could happen if we leave a cast on and it was compartmental syndrome and we didn't take that child back to the doctor. I mean, it's the extreme, but I'm just making a point for you. Now, kids putting casts on can be a lot of fun. And it's actually a distraction method we use. I mean, the doll has them on, and so does she. That's sort of like a spica cast for I don't know what reason, but she looks like a watermelon, right? With the colors. We could also do like colors of team sports, whether football, basketball, for boys, and it takes their mind off of I'm getting a cast on, right? If it's just white, are they going to feel that way? Not really. We had at our hospital 2 pinks, 2 blues, a green, a red, army, yellow, rainbows. I could go on, depending on which one they had there that day. And it would sort of excite the child to go to the cast room and meet the orthotech and choose a color. And that took away the fear, a lot of it. How do we take care of those casts at home? I mean, you've done a discussion question. It's all about cast care. And we're going to make sure that it doesn't get wet. We don't stick things inside, maybe a little cool hair dryer in there. I mean, I've had kids get a cast on, go home, change into their bathing suits and go jump in the pool before their mother could catch them. And they come back the next day, my cast is wet. Why? He went and jumped in the pool. Well, I saw one kid do it 2 days in a row. The mother was about to hit him over the head. Bye-bye, sweetheart. So, making sure that the child knows not to get it wet. And we send them home with bags for bathing, showering, or whatever. Now, sometimes we don't put casts on. The casts aren't what they need. They need traction. Many times you see this with a fractured femur. Well, you have a long bone that fractures and you got these big muscles of the thigh, and all of a sudden it moves. Okay, when it's fractured, because those muscles will pull, and those sharp edges are pushed into the muscles and the nerves. Can you imagine the pain that causes? I can't. The children are crying. It's so miserable. So in the emergency room, if we see these, we will call orthopedic and get a bed sent with traction on. This is called a Buck's traction. And it's like a boot on the lower leg, and it pulls that leg, but it also pulls those bones and it makes them align. And that decreases the pain. It relieves those muscles from spasming. It immobilizes it. It starts to prevent that deformity. And the biggest thing is those muscle spasms. The thing about Buck's traction is knowing how to take care of it. Now, it's a string on a pulley. It goes over the bed. Now, those weights, you need to document what are the weights, how much is on there every shift. That weight must be free flowing in there and never, ever, ever take it off. Because if you take it off, those bones malalign. And again, you're back to where you started from. So that's what we would do with those. Now, here's some names of some tractions. The concepts are what you really need to know about it. There's skin and there's skeletal. Well, skeletal is like that little girl, that little black thing around her head. Those little screws go right into the bones of the head. Those are usually for some cervical injuries or even surgery. There's some surgery on the axis 1 and 2 that they actually do. Has to do with blood flow and cerebrospinal flow, which happens in children, but that would hold that head still so it wouldn't move. A lot of these, like that little girl with the legs up in the air, Bryant traction, that has to do with pulling those hips back and hip dysplasia. It could be that one. Buck's traction, as I said, maybe a fractured femur. And Russell's the same. It's just a 2-point. So, and then these Gardner well tongs right into the head. And it pulls the cervical spine out. Usually when there is a really bad fracture of the cervical spine and you're worried about any sort of paralysis. So one of the things we can do in these really children that have really bad type of fractures, we could do these external fixation devices. You know how what we do with these another way? If you have a leg or an arm that's shorter than the other, we can break it, separate it, put it in this device, and the bone will make more bone and mend it, and you will make that leg or arm bigger. And how do we take care of them? It's pin care and watching for infection. And actually, these kids do very well with these things. And these are like rods and screws and everything going in there, okay? But that's an external fixation device. Amputation. Well, I've seen children born without an arm, a finger, a toe, a leg. I've seen them with one bone in the lower leg. So you're supposed to have a tibia and a fibula. I knew a little girl who was born without a fibula, and there was no way of putting another one in there. So they had to do a below the knee amputation. So again, all those pains, phantom pain, etc., children get them just like adults, okay? And again, what is our goal? We want to give whatever's left, especially a leg, a stump so that we can put on a prosthesis so that these children can get up and get around. I mean, that little girl, I met her when she was 4 years old that had an amputation of her lower leg with a prosthesis. and she met my children for the first time. And I lived in a townhouse with 2 stories. Well, that little girl took off her leg and was chasing my kids all over the house with her prosthesis, trying to bop them all over the head. I mean, she didn't know, because remember, she never had a leg. All she knows is that. So I thought she had adjusted very well. What do you think? Sports participation and injury. Well, this is a big thing with kids. They tend to get up, get out, and go. Adults, hopefully, do that stretching and warm up, etc., before they go. And kids can't stand to lose. So they're going to push themselves further than adults will to win, right? So those overload injuries, etc., are really evident here. Very important that these children get proper equipment. I mean, even bike riding, helmets, right? Making sure they have knee pads, proper shoes, etc., that can help decrease. Overuse syndrome, I think about this with the Olympics and children in gymnastics, right? They're doing the same thing over and over and over and over again. And they do get these little strains that can happen, right? It's the overuse type thing. It's that cyclic over, repetitive. And it can cause problems in the future if they don't take care of themselves as younger children. Now, developmental dysplasia of the hip. This means you have the hip and you have the femur with a socket. Usually you're born with it like this and it moves around and you walk, right? Infants that are born with dysplasia, the socket is up here. You have where the hip goes, and now the bone, the ball of the femur is up higher. Well, it's more girls than boys. Have you ever seen or have children go to the pediatrician? What do they do the first thing? They take the knees up and down and outwards, don't they? They're listening for those clicks. They're listening for, that lack of range of motion. And they're looking for hip dysplasia. Because remember, they heal in 2 to 3 weeks, right? Bones, remember, it's pretty quick. So what would you see? Well, if that hip socket is up here, that leg's going to be short, obviously, right? If you turn them over and look at their buttocks, their gluteal folds, one's going to be higher with it also. You're going to see a positive ortolani and a positive Barlow. You're going to hear that click, click going on. So what do we do for these children? And how do we do it very easily? Well, that little baby there has on what we call a Pavlik harness. And we have it on to cause abduction. So they're with the hip dysplasia, they need to have abduction of the hip. They need those knees up, and we leave that harness on 23 hours a day. We put on a t-shirt underneath, and we put the harness over it, and we will just take it off to bathe them and put it back on. And that is all they usually need to do. On occasion, you're going to have that difficult child that you can't get it back. They might need a spica cast, and then the tendons and whatnot get really tense now. If they get older, they might need some of them cut. It's called otomies, or openings put in it so that they can stretch them to get that hip back in. But usually simple Pavlik harness, and our goal, 23 hours a day, keep it on, and I'll only just look for any sort of irritation from the harness. Now, I said I was going to talk about club feet. There's 4 different types. Don't worry, you don't have to know all those names. Just know, I saw Samantha go, oh, there's too many names there. No, we don't need to know them. There's just club foot. It means it's inward, outward, upward somewhere. It's just not the way it should, period. That's all you need to know. How to correct it's the important part. So here we are with those serial casts. Now, I just recently found this new picture, and if you look at it, it's like every 10 days, they're changing the cast. Remember, these kids grow quickly, right? And their bones mold quickly. So you cannot leave these on for a month and not go back, because you're going to mold these legs incorrectly. So usually it's like every week, you're supposed to go in and get the serial casting done. and it will take those crazy feet in the wrong way and put it where it should. And the name of that is called Ponseti method or serial casting. Now, I mentioned osteogenesis imperfecta, brittle bone disease. I saw one kid in this in my lifetime, and I was afraid to hold him. And he was in the NICU for about 8 months before he went home. What do? There's no cure, nothing we could do. You really can't put casts on them because you're breaking something else. And if you put a cast on, you might break another bone. Many times these children aren't caught at first, and the parents are arrested for child abuse because of these broken bones. I was watching a documentary, actually 2 of them on this, about the parents. Finally, it's like, I'm not doing anything to my child, something's wrong. And then they had to withdraw all the charges, etc. But can you imagine going through all that and a child that has all these broken bones? Well, anyway, what is our goal? Well, we're going to just do supportive care. They give some IV biphosphorus therapy, maybe calcium, vitamin Ds. Does it really work? They really don't know. But what we want to do with these fractures is to make sure that the body maintains a position that keeps them mobile. Many of these children, I used to see at my pediatric hospital, in their electric wheelchairs, coming down the hallway to go to the cafeteria, going beep, 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 beep. And you turn around and there's this little kid, and you know that from their way that their hands and their body shape, you know their osteogenesis imperfecta. They're alert, they're oriented. It's just their bones don't work. Leg calf birth, aseptic necrosis of the femoral head. That means it wasn't from an injury. It wasn't due to an infection. Somehow blood flow stops. They don't know why. It happens, and then it will, through treatment, just stop most of the time. You see it in males ages 4 to 8. Sometimes it can be both hips, but mostly just one. So it's related somehow to blood flow, stopping to go from the head of the femur. What do you see with these children? Well, all of a sudden you're going to see them limping, especially in the morning, or especially after they sat for a while and then they get up. You're going to see them limping. Something's wrong. They'll do an X-ray, of course, because the kid's limping. That always you worry about the fracture, right? So they do an X-ray and they just don't really see much initially. So they're going to say, well, we think this is what it is. And they're going to do something to help that femoral head rest and to stop movement, so that the blood flow, whatever's there, can just go and it doesn't need any changes with all this movement. So put them on bed rest, put them on home traction, that bucks traction. It pulls that leg and lets that femoral not move around a lot, right? And just NSAIDs, ibuprofen, or a type of an NSAID that they'll be taking it. Rarely do they need surgery, but sometimes they do. Remember, any kid with any sort of bone problems, make sure that nutrition is always kept up at home. Remember, too many carbs, especially bed rest, especially on a child that's already a little heavier. You don't want to do that. So fruits, vegetables, and proteins would be a diet for that child. Now I'm going to go over 3 different types of curvatures of the spine. Kyphosis is the humpback. It's the upper spine, the thoracic. Lordosis, and I'm going to get to a condition, a neuromuscular condition that these children have. It's the inward lumbar spine. They sort of are leaning backwards, okay? These children, it could be heavier, could be some contractions, could be, it just happens, could be trauma, could be any of them. Now, the one type of curvature that, you will see the most, therefore tested on the most, is scoliosis. Now, scoliosis is an S-shaped curvature of the spine. Sometimes they're born with it, but many of the times it happens as they get older. Now, what happens right at 12 to 14 years old? that pre-adolescent growth spurt, right? They grow 25% of their height. And usually this is when you will see it evident and you'll see them curved. Now, the problem is with the curvature, if it curves a lot, one of the lungs is going to get compressed. So you're decreasing lung capacity. So they say, and there's two different numbers I see, 40, 45%. Up to that, we can just do bracing. After that, they need to do surgery because the bracing isn't going to help. So what they do is, if you see this little brace they put it on, it holds them straight. Again, 23 hours a day, take it off a shower, and you wear a t-shirt underneath because of the sweating and because of the material against the body, and of course that rubbing thing. Well, these are your adolescents. What is their big thing? Body image, right? They don't like these things, but it's something that they do need to have on, and they do correct. My daughter's best friend since the age of 4 had scoliosis and went through it. And what they do is put the brace on, and then they go for physical therapy, and they strengthen the muscles in the back, and that really, really helps. One of the things about post-operatively, these children go and get these rods put in. What they do, these rods, they take the spine and they put little screws on either side of the vertebrae and put a really stiff rod up the back. And they try to straighten out that curve as much as they possible. Now, post-operatively, these kids are on bed rest and they're flat. And the only way you can move them is they need to be log rolled, right? A pillow between their legs and turn them in one motion to the side, for toiletry, bowel movements, for changing their beds, bathing, etc. So log rolling is very important on that one. Osteomyelitis, an infection of the bone, stepped on the rusty nail or whatever it is. And all of a sudden the kid will have, whether a foot, a finger, wherever it's at, you're going to see this redness. You're going to see maybe some oozing pus out of it. It's going to be hot, swollen, and painful. A lot of these children end up with fevers. And with that, it is bacterial. So there is leukocytosis or an elevated white count. They will do a culture, make sure what it is. And then they're going to put these children on a minimum of 3 to 4 weeks, up to several months of IV antibiotics. They're going to have some sort of long-term IV access, a PICC line, a Broviac, something to make sure that they have good access. And most of these antibiotics are those aminoglycosides again. These are the peak and trough. Worry about kidney function, hearing loss, really need close blood work on these children to make sure that their livers are not killed and that their kidneys maintain okay. Most of the time we like these kids, depending on where it's at, on bed rest, elevating that limb with like in the toe. Pain and NSAIDs usually are just what they need. Tylenol even could be used. And the one thing about, again, children, bones, bed rest, nutrition. Fruits, vegetables, and high in protein. All of those things are what they really need to help them. And again, they're isolated, right? They're going to be home from school. They do need some sort of activities, for depression and feeling that isolation, etc. Ewing sarcoma is a tumor, and it's in, again, these bones, femur, tibia, ulnar, humerus. It could be in the scapula. And you see that little picture on the left, it's, the scapula, and you see it in the jaw. And again, radiation, radiation, chemotherapy, and surgery if you can. I mean, can you remove a scapula or a piece of it? It all has to be looked at. And again, you always worry about being already metastasized. So if it's already metastasized, cases of curing this are less. JIA, juvenile rheumatoid arthritis. Doesn't matter if it's an adult, doesn't matter if it's a child. It's the same treatment, it's just on pediatric doses, right? Why does it happen? They don't know. It's an immune something that happens, or it could be environmental. I've seen it as young as that ages 1 to 3. Many of these children have this stiffness and they're never diagnosed till later on in life. So many times it's undiagnosed. What would you see? Well, I know when I'm done teaching, to get up today, I'm going to have to stand a second and stretch because I have rheumatoid arthritis myself. In the morning, I have to sit there and just stretch before I can even take a walk. And it's difficult. You'll see me wobbling in the morning. And many times you'll see me limping. The joints will swell and disfigure. I don't really have that bad, but it can be quite bad. And another thing is uveitis, which is the redness of the eye. So these children do need some good ophthalmology follow-up yearly. How do we test for it? Well, I wish they knew. Took me only about 8 years to even get a diagnosis. And they argued with me the whole way through. So what do? Well, you're going to look at some of those inflammatory factors, the SED rate, the C-reactive protein, ANA, RA factor. Sometimes the white count is elevated when you're in exacerbations, but it's really, really not known. But you do a little bit of everything, and if all of them turn up, then they're going to say, okay, you have rheumatoid arthritis or JIA. What is our goal? Well, we want to keep this kid up and moving, prevent those deformities, and hopefully decrease the pain. These children usually, initially, when we're diagnosing, they're usually in a lot of pain, so they'll give some corticosteroids, but it cannot be long-term. You will end up long-term prednisone therapy will end up maybe in Cushing's syndrome. It happened to me, it can happen to anybody. They'll put these children on Humira, Enbrel, Cimzia, one of those biologics, and usually together in combination with methotrexate, which can be pills, liquid, or it can be injections. So I take care of it. Well, you all know I go into my pool is my savior. And what does it do? It keeps me moving, and it's very easy movement. So that helps. That's the physical and occupational therapy I give to myself. Making sure taking your medicines on time, being compliant, so important. Sometimes these children, even adults, they like heat. I hate heat. Heat makes me horribly worse. I like cold. Get me a pool of icy water and I stick my feet in it and I'm happy. But other people like heat. So whichever one works. Again, these children need the parents there because they're going to be on medications. It's not just for 7 days, it's going to be for life. So they need good support. So lupus attacks organs and JIA attacks the joints. They're both autoimmune diseases, okay? Lupus, you usually see at that pubertal change, girls 10 to 19 years old. And a lot of times there are families that also have it. I live in Florida, so sometimes it's that overexposure to sunlight. So that's the way I usually see it. You're going to see that butterfly rash on the face. Usually children that are just being diagnosed are going to be going through this nausea, vomiting, diarrhea, and pain, and they don't know why. So they go to the doctor. And then it goes further, and they start with weakness and the joint pains, forgetfulness. And when they get to the point of seizures, then they know what's going on. And also proteinuria. Now we know the kidneys are involved also. Our goal of treatment are to prevent any of these flares going on. These children, depending on what, most of these actually are on low dose prednisone and some other medications. It all depends on the doctor. So again, making sure they're compliant, they go to their follow-ups and keep out of the sunlight and wear sunscreen, right? So Kristen, 10 years of age, sustained a fracture in the epiphyseal plate in her right fibula when she fell out of a tree. When discussing this injury with her parents, the nurse should consider what?
D.
It is the growth plate. Absolutely. Very good. All right. Neuromuscular or muscular dysfunction and cerebral palsy. You know, this is that movements, postures, they just can't move the right way. It's like a light switch on and off, like as they're moving and the light switch is going on and off. They just can't get just a smooth motion, you know, like we have. Many of these children do have epilepsy. Sometimes you're going to see these children have problems in their brain. There's some sort of abnormality or an occlusion. Many of these children are low birth weight. Some of the ones that I've seen and have followed through with is those children that's had an anoxic or an hypoxic episode, especially at birth. I've seen children that they tried to go for a vaginal delivery, and at the last moment, the kid can't come out. So they have to do emergency C-section. And sometimes there's a hypoxic episode, which could lead to cerebral palsy. So not all children you'll see at birth or know there's a possibility of cerebral palsy. We don't know what all goes on in that birth process, you know, and maybe there was decelerations or whatever that was going on. So a careful assessment. Why do you think we learn all the growth development, the fine motor skills, the gross motor skills, seeing if they're doing what they're supposed to do? Because if they're not, we're going to start looking for it, right? You know, as they get older, we're going to be seeing that hypertonicity, that poor posture. They're not going to be able, many of them, to stand without support of some sort or sit without some sort of support. We're going to be doing some sort of MRIs of the brain, neuroimaging, and of course, metabolic and genetic testing will be done to see if that's what's causing it. So like I said, why do we do those, you know, growth and development milestones to look at? We're going to see delayed gross motor or abnormal looking motor skills, abnormal postures, and you're going to see sometimes they're not able to speak, even they're a verbal. Now, I have little Christopher who was in my when I was doing the clinicals for when it was pediatrics when I was on ground, and little Christopher was spastic cerebral palsy. The kid was nonverbal. He didn't even eat. He had a G tube because the mouth didn't work the way it should. Now, many years ago, I worked with these children, and these children, we didn't do what we do today. Today, they get occupational speech, physical therapy, and you're like, well, how do we know this kid is understanding? Well, that kid would see me across the room when I came to clinicals, and the smile that went from ear to ear could launch 1,000 ships. That kid knew I was going to run up to him, give him a big hug, and tickle him. And he just knew that I was going to do that. They gave him, for speech therapy, a pad, you know, where he could push things. This child was learning colors and shapes. He was 7, and yeah, that's minimal, but it's more than they ever expected him to do, because he's a severe spastic cerebral palsy who is in a wheelchair, can't walk. And yet, of course, he has to be strapped in so he doesn't, you know, have one of these spasms or just movements and fall out of it. So these children are smarter than we think. Our goal, especially with those even milder cases, because these are the more severe, we want them to be able to move, right? We don't want them stuck in a room. We know that could cause a lot of things, that aggression and that just regression and aggression and being angry and mean. So these kids, any way that we give them locomotion, many of them are given wheelchairs or walkers. This kid has a tricycle. They've put splints on his legs, they strapped him to the wheels, and that kid can move around. And of course, that gives him freedom of movement, which makes a happier child. Jonathan had the iPad and he could talk to us and say hello to us. And I thought that was the best thing. Going, at 6:30 in the morning, which is way too early for me, and seeing my little Jonathan, and he'd be smiling and saying hello because he'd be one of the first kids in. We want this kid to be given as much education as he can, meeting goals and then resetting goals for even more to be met, and having him with other children. Seeing what other kids do helps them want to do more, and it's really good for their mentality. We put those braces on to hold their legs, their ankles. Yes. Is there somebody? All right. They put on these ankle foot braces, wrist braces, because they want to give them some control at times. Like if they're trying to eat, a wrist brace would hold it from moving around. Sometimes they do a surgery. They cut tendons to relieve the stretching and these tension. They give botulism, works great on these kids. Little Jonathan got levodopa carbidopa. The other name is called Cinemet. It's used for Parkinson's because of those shaking tremors, and it worked, and it did improve his movement. Now remember, most of these children have epilepsy, so they're on some sort of seizure drug, right? So phenytoin causes what? The hypergingival, the gingival hyperplasia, right? So good mouth care, really important. Prognosis, many of them do well. Many of them can be a part of the community, and many of them can't be. It all depends on their level of the CPs, from mild to severe. Taking care of them is making sure all their needs are met, that the family has what they need to take care of them. They know how to give them medications. Always be safe for these children. These kids need all of those strapping in and watching, because they can fall very easily. Getting them recreational activities. I mean, one day they filled up a bunch of these little kids' pools outside, and had these children with cerebral palsy dangling their feet in it or sitting in water and splashing in it. And these kids' smiles were amazing. It just, again, it gives them something to have fun with, right? Can't be all physical, speech, and occupational therapy, which is what all the time. And always support that family. Now, neural tube deficits. Do you remember in pharmacology, they said you take folic acid to prevent neural tube deficits? And you're wondering what a neural tube deficit was, right? You learned the words. Well, this is what a neural tube deficit is. It is when the meninges and the spinal cord are born on the outside of the body. Well, think about it. It's pulled. So nerves, meninges, pulled up and out. So there's going to be nerve damage on the lower extremities. Not only nerve damage, you have to worry about bladder function and stool function. So lower extremities are mostly, whether it's no movement or a little movement, it's all those nerves are stretched up and out. So what do we need to do as nurses? We get a call, you're having an infant come that has a myelomeningocele. How do you prepare for it? Well, that blob on the back needs moisture to protect the tissue integrity, and it needs a sterile dressing. Your priority is controlling infection on that child and getting it covered. This child will be placed on his belly, never on its back, because of the blob, right? So they need to be monitored to worry about apneic spells, etc. A lot of times these neural tubes, it's that folic acid thing, but it could be maternal obesity, diabetes, and even low B12s can cause it. So we get this beautiful child and we make sure that it's covered with a moist, normal saline, sterile normal saline is what you need, and a dressing over it. And we get him a couple days later, they'll end up doing surgery and putting it back in. These children, because they're going to have issues with urinary retention and surgeries required immediately at birth, they're made latex allergy so that we don't ever over touch them with it and prevent anaphylaxis. Basically, that's what we do. I met a boy with this, a myelomeningocele, beautiful, gorgeous, big head of hair, looking like this child right here, big myelomeningocele. And I'm in the room, all the other nurses had gone or whatever, break or gone to get stuff for their day. And there was a mother standing over this baby crying. Wasn't my kid, but I can't leave a mother crying over a baby. So I said, Mom, what's wrong? She said, the doctor's telling me, you know, my babies may not make it. And I've worked so hard to have this baby and I don't know what to do. So I said, Mom, you look like a great mom. I think you're going to do great with him. And I think that you'll make sure this child gets everything he needs. And I know that you're going to be taking care of him really well and that he's going to be beautiful. Look, I said, look at that face. I said, number one, sit down. I wrapped the kid up and I put the child in her arms and let her bond. And that's the first time anybody let her do it. Well, the story goes, 14 years later, I'm down in the emergency room and I see somebody pointing to me with a kid in a wheelchair next door. It was this mother, pulled me out, wanted to give me a hug, tell me thank you, that my words of encouragement gave her the strength. Manuel Louis had just gone to his 8th grade prom, had a date. He's in mainstream school and did very well, had A's and B's. Also, and this just blew, had a keychain with a plastic picture with me holding Manuel Louis in it that she carried around for 13 years. Now, do you see how you as a nurse can make a difference in not only this kid's life, but the parent's life and the family? And to this day, it still warms my soul that child did so well. And that's that folic acid thing I told you about. Now, spinal muscular dystrophy, you've heard of muscular dystrophy. Well, Wernicke-Hoffman is the worst of the worst that you can get. It's congenital and it's called floppy infant syndrome. And we usually see it in the first 2 months of life. We'll figure it out because these kids can't even lift their head up. And these kids are weak. They don't even cry good. And they usually die by age 2. So it's a horrible diagnosis. And that is called Wernicke-Hoffman. Now, Duchenne muscular dystrophy is the muscular dystrophy that you're going to be tested on all the time. It's just like tetralogy of Fallot. I know you're going to see this on HESIs and your NCLEX. And Duchenne muscular dystrophy, or DMD, and I had some students do this as their project, which I thought was amazing. It is the most severe and most common of all muscular dystrophies. It is from mom. It's an X-linked recessive that causes these children, they're boys, ages 3 to 7, you start to see it. So about age 3, they're going to be walking okay. You're going to see hypertrophic calf muscles on these children, like big, big muscles. And then all of a sudden, they're going to start waddling and falling. And progressively, they're getting weaker, weaker, and weaker. Now, how do we diagnose this DMD? Well, we need to look at the muscles and the nerves and seeing if there's any delay in the movement of them. So they shoot a little bit of electricity up the nerve, like that picture up top, and the muscle will contract by itself. Now, one of the things you need to warn your parents about is because they are taking muscles and making them move, it's like they've just gone to the gym. it can be really sore afterwards. But again, it's temporary. So like I said, these children, you're going to start seeing that waddling, like a pregnant woman, back and forth, trying to get their feet on the ground. They don't fall, but they will be falling. Also, they're going to do Gower sign, which I do every time I'm on the floor. Means I take my hands and I walk up my legs to stand up, because they can't just get up like a normal 3 to 7-year-old kid and run. They can't. The lordosis, that big curvature in that lumbar spine. And as I said, those enlarged muscles, mostly in the lower legs, the thighs, and the arms. You can also have it too. And you will see them getting more and more progressively weaker and weaker. They also are going to have some sort of cognitive delays, mental impairment. And because they can't move good, you're going to see them a little heavier. So how do we treat this kid? There's no treatment. There's no cure. These kids are going to end up in respiratory and cardiac failure around adolescence, and they will die no matter what we do for them. We will try to maintain the function of them, their muscular strength, as long as they can. Good physical therapy and occupational therapy. And again, checking the genetics. So if that mother wants another child, she's going to know what her chances are of giving another child this. Guillain-Barré, did you just study this in the Med-Surg 2? If you're in Med-Surg 2? Well, Guillain-Barré is where the nerves stop working. And if you don't have nerves working, it's the task that the nerves trying to do will not work. Like if a nerve's trying to make a muscle contract to walk, it stops. Now, it's called infectious polyneuritis, and it causes paralysis. And it starts from the feet and it works up. Usually you'll see it in those kids ages 4 to 10. So what are you going to see with these kids? Well, you're going to see them starting to get really tender, numbness, weak, falling, paralysis as it works, and it's ascending, feet coming up. When it gets to the level of the bladder and bowel, you might see incontinence or constipation. And then your biggest priority to monitor is respiratory status, because the phrenic nerve does what? It makes the diaphragm work, which is what? Breathing. If you don't breathe, how are you going to breathe? These children end up on ventilators and they're not moving any air at all, but they're still cognitively completely aware. These are normal children, normal adults, normal. So these kids, they know the surroundings, but they can't feel anything. So they're on a ventilator, depending on how long it takes. We, of course, will be monitoring cardiac, the respiratory, the O2 sat monitors very closely. We're going to be given IVIG. That's the mainstay treatment. Some plasmapheresis, which means trying to remove some things from the blood that they don't think is working good, and maybe steroids. But IVIG is a big thing. And then all of a sudden, you're going to see the kids start taking some breaths. And then all of a sudden, it goes down to the feet. Now, once it's completely resolved and all of the nerve comes around, these kids with therapy can be absolutely normal again. It could be 2 months back and forth. It could be a year or two back and forth. It's all different. Every child will be different. Tetanus, stepping on the dirty nail and it causes tetanus. So that's why we get tetanus shots. Well, tetanus is you get a wound and it starts with this infection that goes on. And what you see is it's all about lockjaw. It's all about the neck, stiffness, and then swelling. Then you can't swallow, and then you can't breathe. And then everything goes like tight, stiff muscle, like always as you are making a muscle with your upper arm, like you're sitting there, always clenching a muscle. Can you imagine how painful that is? These children will be paralyzed with a really powerful muscle depressant, right? Or relaxant. They're not going to be able to move because of the pain if they are. So they'll be paralyzed, they'll be sedated, and now we got to worry about keeping their respiratory moving, preventing those infections. We will be giving that tetanus, the antigen, the booster, the vaccine, and we're going to work closely with these children. Many of them will die within the first 3 days. If we can get them over 4 days, they will make it. But getting that tetanus booster as quick as we can does help the prevention of tetanus. We will need to clean that wound. We will need to be giving those tetanus toxoid or antitoxins, whatever. And then hopefully we can get this kid through this. And that's all I just said. Botulism. Any of you have a grandma that says your kid's constipated, give a little bit of honey, give a little bit of Cara syrup. That's going to help them move their bowels. Well, it's dangerous. No infant, and I think the book says up less than 1 year, I would say less than 2 years, should never get honey. And the reason is we don't know how it was prepared, if it was sterile, how long that bottle was at the factory before it got to us, or sitting on the shelf, or all of those things. And it could have some anaerobic bacillus in there, okay? And what happens with botulism, you will see after the ingestion, it's only like half a day to a day and a half later, all of a sudden, these children, now if they're infants, you're going to see that vomiting. I mean, vomiting. And you might see some of the other stuff, but usually it's the vomiting that brings them into the doctor. But what happens is life-threatening respiratory paralysis, which, how do we treat that? Well, we're going to support the respiratory system, have them on that ventilator, again, always making sure they're getting their nutrition, and we're going to give that IV botulism immunoglobulin. And hopefully we'll turn them around, and we will continue this until the paralysis goes away. So honey or any of those corn syrups, don't give them. Spinal cord injuries. You know, I was many times the primary trauma nurse on duty, and which means that I was an experienced nurse, and I'm in charge of a child if they're brought into us in any sort of trauma alert. Usually it was from the helicopter. You go up to the helicopter, get the kid, bring it down, put it in a room, and start treatment of it. Now, what can cause a trauma? Well, a lot of anything, right? It could be a car accident, sports, could be that coup de grace, which is flexion, hyperflexion, hyperextension of the neck, can also cause some of that type of spinal cord injury. Your priority on any child with a spinal cord injury is proper immobilization. Make sure that neck does not move. And I was in charge of that. I told you I would have my little guy here. Say hello. Say hello. All right, you don't want to. Goodbye, pumpkin. Give me a kiss. I got to finish. All right, no kisses. I gave you a hug. That's what I have to put up with. And he's 6. So I have a story about a little 16-year-old kid, and he was a full man, slid into third base, his head hit the knee, and everybody heard a crack. By the time they went over to him on the base, he already had numbness on his right leg, and the left leg had partial numbness. So they called, of course, 911, which called the copter in. They put him in a nice collar, strapped him, taped him to a board, and got him to me. Now, he's in my care. We had to, even because of the extent of the injury, we had to do an MRI, which meant we had to move him from the board onto the MRI table. And in the meantime, I'm trying to keep this kid calm, talking to him. He had what we called an angulated C5, C6 fracture, which means instead of his spine straight, it angulated. He had nerve damage. And any other movement could have caused even more, right? Well, this kid ended up, we got him to the MRI. I got him up to the ICU. We put those tongs in, right? Pulled his neck, put him on a cool bed because the cold helps with swelling, and that pulley, right? And the next day he went to surgery. I went to see him 2 weeks later up in his bedroom, in his room. All of the left leg had come back, and there was slight numbness in the right. And he was going to inpatient therapy, rehab. And he gave me a hug and told me, thank you for keeping him calm. A year later, he came to visit me in the ER walking, and he was perfectly normal, fine. So just a nurse, made sure that that child had a life to live for. And he was a good looking kid. So a progressive infantile spinal muscular atrophy, and the most common paralytic form of the floppy infant syndrome is which one? Do you remember which one I said?
D, was it?
It's Werdig-Hoffman. I won't let you suffer. It's Werdig-Hoffman. DMD is the one that you see, that's that muscle wasting. Any questions? Do you like my stories? I got lots of them. All right, let's do our Kahoots. And once our Kahoots done, that's it. And there's 39 questions today, so not bad. Let's get her done. Week 9. I'm still amazed. Almost over. I might have to say goodbye to all of you. I'll tell you. What is the priority for a nurse to assess following a CAS application? So when we're looking for CAST application, remember it's those 6 Ps, right? The pulses, the pain, the movement, the sensation, pulselessness. Those are things that we were going to not only do ourselves, but we're going to be telling the parents to check and the child. What should the nurse monitor after a soft tissue injury? It's just a bruise, right? So again, any soft tissue injury can be more extensive than you can really see. So always check in those neurovascular signs and pulses, right? Important. Remember, ortho, priorities, neurovascular, and your pulses. A fracture that penetrates the skin is called So as simple as just a break, no penetration of the skin, compound. It's compounded because it's sticking out. So what's the treatment for that one, right? Got to remember those things. What is the priority nursing care of a child with a compound fracture? So the number one priority, if it's an open compound fracture, our worry is sepsis, infection, IV antibiotics. Are we going to be doing neurovascular signs? Absolutely. Capillary refill, you're checking pulses. Yes, but we need to get those IV antibiotics in. And if you ever see a question, it's IV antibiotics is your priority. What is priority nursing care for a child who fell off a second floor balcony? You know, I've seen this. Kids, climb up on a table, get up on a ledge, and they fall off. Why do they do that? Why were they let out there? I've actually seen two. Kids do the darndest things. Again, anytime you're worried about something with the spine, immobilize that spine. Make sure until it's cleared, we keep on that collar. Principles of managing soft tissue injury include what? So it's rice. Rest, ice, compress, elevate. Good job. You do that one. Epiphyseal plate fractures in children may do what? What is that?
The growth plate.
Yes, it is. It's a great name, isn't it? Epiphyseal plate. Why can't they say growth plate? So we're always worried about the growth of the bones, whether it's not as long or it's crooked. Very good. What findings for a patient in skeletal traction indicate peripheral neurovascular impairment? So we're always going to be concerned about pulses, all right? I mean, the first we do is check the capillary refill and go, oops, check for pulse, it's gone. Now that's an emergency. Need to get the blood flowing. Multi-select. How should the nurse care for the skeletal traction for a child with a fractured femur? You know, a femur fracture could be either skeletal or skin traction. You know, years ago, they all got a diamond pin and were in the hospital for a month. You know, today we put them in that bucks or skin traction, and now they do a surgical repair by inserting a rod up the femur, and they're sent to therapy, and it's not a month-long treatment anymore. So we want to make sure the weight is documented, and we want to make sure that that weight is dangling there. And we don't want the foot to be at the end of the bed. We want to make sure that it is getting good tension and pulling. When caring for a 9-year-old in bucks traction, what action by the nurse is correct? Again, always checking for pulses, very, very important. And we're never, ever going to take the traction off. The weights must maintain. They're never to be taken off or bath, anything. They must be 24 hours a day. A multi. Which assessment indicates an infant has developmental dysplasia of the hip? Means that hip socket's not where it should be. That's why we're doing those good things in the pediatrician office when they're first visits. We're going to look at those folds, looking at it, and we're going to hear those clickings that are going on there. Very good. We're going to see irregular folds, a shorter leg also. What position do you put the legs of an infant with hip dysplasia? Yeah, we put them in a Pavlik harness, but what position does that put them in? And it's abduction. Remember that word. What statement by parents indicate more teaching is needed regarding their 2-month-old infant with club foot? Give you a couple different pictures of the type of club feet. Doesn't matter what type it is, they can all be treated in the same manner because they're so flexible and they heal so quickly. Now, waiting for a month is way too long. Should be started as soon as possible. Let's take that window of 2 to 3 weeks for healing, right? And when they're grown up, they're going to be needing treatment. It could be special shoes or something. So, and making sure that that leg is not shorter than the other. So there are going to need follow-up as they get older and grow. And of course, every week they need to be back for casting. A multi. Osteogenesis imperfecta. And I put that picture down there to show you how this person did not get somebody who put them into a workable position. Can that person go into a wheelchair and be mobile? That wouldn't be a good thing with these children. You can't make them be alone in a room. So it's the bones are crooked, they're brittle, and we don't even know why all the reasons for that are. Are we going to do aggressive physical therapy on osteogenesis imperfecta? No. What's going to happen? You're going to break bones. Literally picking that child up to put a diaper on, you could break the bones. That's how fragile they are. Holding them could crack their ribs. What is pathologic cause of leg calf birth disease? And you could see the fuzziness on that right-sided hip. See that little fuzzy look? That's the where the area of breakdown has occurred. You don't always see that at first like that. Might be slight, but it's an ischemic aseptic necrosis of the femoral head. That means it's not an infection, has to do with decreased blood flow. They don't know why. How do we treat it? Well, we're going to put them on some bed rest, maybe some traction and good nutrition. And NSAIDs are the only thing for pain they need. Kyphosis. Which one is that? And that's the thoracic spine, humpback. Lordosis, what's that? And that little girl really shows it very, very well. And that's the inward curve of that lumbar spine. And you can see how they sort of even lean back with it. And that's with Duchenne muscular dystrophy, you see it. Scoliosis. So again, scoliosis, S-shaped curve. And remember that we treat it in two different ways, surgery or medical treatment. So an adolescent with scoliosis to have up to a 45% curvature of the spine would need what? After that, what do we do? Before that, how is it treated? That's, I said, between 40 to 45. You'll see it written both ways. So if it's up to 45, we're going to wear them in a brace, 23 hours a day and physical therapy to strengthen those muscles. After that point, they're going to have to do surgery, the Harrington or Luque rods, where they insert that metal rod and then postoperatively it'll be that log rolling that you need to do. What is osteomyelitis? So osteomyelitis is an inflammation or infection of the bone. And goals for JIA include juvenile idiopathic arthritis. Just about to have a big storm here. If I cut off, it's my daughter's house does during the storms. And it doesn't really matter if you're an adult or a child with rheumatoid arthritis, the treatment is all the same. So our goal is to reduce the pain and the swelling. And a multi. What might you anticipate for a child diagnosed with JIA? What would you see? So the joints can become disfigured. Again, difficulty walking, especially in the morning with that stiffness. And remember those eyes, that uveitis. Facial rash is lupus. It's not JIA. A multi. What can help a child with lupus prevent exacerbations or flares? So wearing that sunscreen, decrease that exposure to sunlight. And this would be that immunosuppressed child that would require prophylactic antibiotics or steroids before like dental work and minor procedures. What organs can lupus affect? The answer is any organ. Absolutely any organ lupus can affect. You know, the one that I think is the most concerning is, you know, when they affect the brain, and then it can do all those neurological problems. What is cerebral palsy? Cerebral palsy is all about the muscles and the movements and the coordination. That is cerebral palsy. It has other things to do with it, but that's the basis of it. A myelomeningocele. My Manuel Louis. Remember, when this occurs, it just pulls and it stretches nerves and it creates a lack of nerves down in the lower extremities, which can affect many different things. So it's a hernia of the spinal cord and the meninges. And remember, the spinal cord in that area is all the nerves. So it's stretched and pulled out of the skin. So that's why it creates all the problems. Infants with myelomeningocele demonstrate what? It's motor and sensory impairments. They can't move, they can't feel it. Very good, both of them. Myelomeningocele have decreased motor and sensations of the lower extremities. What should the nurse monitor closely? And it's all about urinary retention, okay? Remember, the myelomeningocele causes a decrease in nerves from like the waist down. So our biggest concerns is urinary retention. They don't feel it. They don't know they have to urinate, and it just gets bigger and bigger and bigger, the bladder. That is the biggest concern of all. That and your constipation also. They don't feel it. A key feature of Duchenne muscular dystrophy is what? DMD is all about the muscles getting weaker and weaker and weaker. So it's progressive muscle wastage to the point where the muscle of the heart stops and the muscle of the diaphragm stops. And that's usually how death occurs, usually in the teenage years. One of the procedures that a child with possible Duchenne's may need to diagnose this condition is called what? And that's your EMG, electromyography. And what is that test? What does it look at? Well, it takes these little tabs, or even sometimes needles will put in, and they'll shoot electricity right there into the muscle and see if it spasms and how quickly and how strong it spasms. And if they're showing that it's decreased, they know that it is a muscle wasting problem. Remember, they hurt. It's like going to the gym and working out. They do hurt, so let them know, and the parents know that it's just temporary. How is Duchenne muscular dystrophy inherited? It's from mommy, X-linked recessive. A lot of mothers really feel guilty when they find out their children has it and they caused it. In caring for a patient with Guillain-Barré, the priority concern is what? And it's all about the airway. Remember, it comes from the feet and works up as ascending. when it gets to that phrenic nerve and stops them from breathing, if we're not watching that, that's not a priority. I mean, airway is always number one, right? They're not going to breathe because that phrenic nerve is not telling the diaphragm to breathe. For a patient suffering with Guillain-Barré, they would complain of weakness. That was what? And this is what we call ascending. Means it goes from the feet and it works upwards. And it's that all of a sudden that stumbling, weakness, falling down, and then usually the urinary incontinence then will bring them in. And that usually is telling physicians, we need to look what's going on here. It could be Guillain-Barré. A multi. Treatment for Guillain-Barré is what? I mean, Guillain-Barré is usually a couple of weeks after upper respiratory. They think it's something to do with that. They're really not sure, but it's shown that many of them have had an infection like that a couple of weeks earlier. So usually it's viral. So antibiotics have nothing to do with it. Heparin, it's only used for prevention of blood clots. It's not for the disease, but we're going to give IVIG and we're going to make sure that the child's breathing or we're going to breathe for them. What type of cerebral palsy causes hypertonicity and poor fine motor skills? My little Jonathan. And usually when you think of cerebral palsy and questions are talking about that, you're usually thinking that it's going to be the spastic. Spastic is the one most common, the one that we think of when we think of the kid with cerebral palsy, you know, that's in the wheelchair, or the one that with those movements that you see, that hypertonicity. It means the muscles are always in spasm. What priority action should a nurse take to a patient with a suspected spinal cord injury? Always watch the spine, keep it together. You can prevent a child from being paralyzed. And when you know that you've prevented it, the best feeling you could ever have. I made sure, and that kid today is a normal child. Well, you should get a tetanus shot. How many years? Who should get a tetanus shot every year? No, you should get. You know, this has changed so many times during my career. I mean, it used to be every year, every 2 years, every 5 years. Now it's every 10. It has changed. They found that give the tetanus shot every 10 years. And if you have an incident, they can give you a booster. And that's the way they feel that the tetanus shot works the most effective. What is a symptom of tetanus? What is tetanus? Stepped on that rusty nail. How do you treat it? Well, we're going to be cleaning that wound, number one, and putting a little soap and water and a dab of antibiotic ointment. And then if we get to the point of tetanus being, you know, severe, it's called lockjaw. Remember, it's all the upper airway and it squeezes and laryngospasm and you can't breathe. So we're going to give the tetanus toxoid, ventilation support, and hopefully we can get them through it. Last question. Most common causes of spinal cord injuries are what? it's motor vehicles are always the biggest for injuries, right? I've always said that this whole course. Driving and of course sports, like my little kid who decided his head should meet a knee and almost hurt himself for life, but thank goodness we didn't. Number 3, Jess. Good job, Jess. Number 2, Ashley. Good job, Ashley. Number 1, we have a newborn. Number 4, Michelle and Trell. Good job, guys. So do you all have any questions at all you need from me answered? Remember, tomorrow, 2 p.m. is when I'm doing the review. If you want to stay after and get more intense, ask questions, ask about concepts, help you get through this, make you through this. I'm here for you. I'll work with you. Those who want to do math, I was asked earlier, I could do it next Tuesday before it to give you that review that you need. There are some of you who do. So I'll be all day Tuesday, whatever you need. I'll be waiting for you. So you all have a great day. We're done early today. And see you next week and do good, all right?
I have a
Bye,
question.
guys.
Professor.
Sure.
Yeah, about the paid assignment.